Syncope is a clinical condition affecting all age groups, crucial in emergency admissions. Diagnosing syncope poses challenges due to varied presentations. Emergency departments, though limited, can differentiate life-threatening conditions through detailed history and examination. High-risk patients require identification for targeted treatment. This review discusses syncope management in emergency settings. Syncope is defined as a transient loss of consciousness with rapid onset and recovery. It can occur in various diseases, from benign to malignant. Pathophysiologically, it often results from inadequate cerebral perfusion. Epidemiologically, syncope accounts for 0.6 to 3% of ED visits, increasing with age. Common conditions include reflex syncope, orthostatic syncope, and cardiac arrhythmias. Syncope classification involves cerebral hypoperfusion, cardiac output, and peripheral resistance factors. Reflex, orthostatic, and cardiac syncope are common types. Cardiac or vascular diseases increase malignant syncope risk. Understanding these classifications aids in distinguishing benign from malignant causes, crucial for effective management in emergency settings. Patient characteristics are vital in syncope evaluation. Elderly patients often present atypically, increasing malignant syncope risk. Heteroanamnesis provides essential clues, especially post-syncope confusion. Witness accounts clarify causes. Comprehensive history helps identify syncope etiology, guiding appropriate management. Key questions in syncope history include episode duration, frequency, and triggers. Understanding these factors helps differentiate causes. Position during syncope and accompanying symptoms provide diagnostic clues. Medical and family history, including drug use, are crucial for accurate diagnosis and management. Evaluating syncope involves assessing episode duration, frequency, and triggers. Infrequent episodes suggest benign causes, while frequent episodes may indicate serious disorders. Triggers like exercise or emotional stress can reveal underlying causes. Understanding these factors aids in accurate diagnosis and management. Position and symptoms during syncope provide diagnostic insights. Standing syncope is often benign, while supine syncope suggests serious conditions. Accompanying symptoms like lightheadedness or palpitations indicate potential causes. Evaluating medical and family history is essential, especially in younger patients. Initial syncope evaluation starts with assessing airway, breathing, and circulation. Vital signs, including orthostatic readings, guide further evaluation. A thorough physical exam focuses on neurological and cardiovascular systems. Identifying critical findings aids in effective management and treatment. The diagnostic approach to syncope includes physical examination, ECG, POCUS, and selective imaging. ECG rules out cardiac causes, while POCUS assesses cardiac function. Laboratory tests are based on clinical suspicion. Diagnostic tests follow initial evaluation and stabilization, ensuring targeted management. ECG is essential in syncope diagnosis, revealing subtle but important findings. It identifies heart blocks and pulmonary embolism signs. Rhythm strips may show transient arrhythmias. ECG aids in diagnosing conditions like ventricular tachycardia and STEMI, crucial for effective management. Sinus node dysfunction and supraventricular tachycardias are key ECG findings in syncope. Sinus node dysfunction appears as bradycardia or pauses. SVTs show absence of P waves. ECG monitoring captures intermittent pauses, aiding diagnosis and treatment. Persistent bradycardia requires intervention. Brugada syndrome and other ECG abnormalities are critical in syncope evaluation. Brugada syndrome, Wolff-Parkinson-White syndrome, and long QT syndrome present distinct ECG patterns. These conditions can lead to ventricular arrhythmias and syncope. Identifying these patterns aids in targeted treatment. Point-of-care ultrasonography, POCUS, is valuable in syncope evaluation. Bedside echocardiography assesses cardiac conditions like acute coronary syndromes. Pulmonary views check for pneumothorax. Abdominal and vascular examinations identify potential causes. POCUS aids in rapid, targeted diagnosis. Laboratory testing in syncope includes complete blood count, venous blood gas, cardiac markers, and D-dimer. Tests are based on initial evaluation findings. CBC rules out anemia, while cardiac markers assess ACS risk. D-dimer evaluates pulmonary embolism risk, guiding further management. Computerized tomography, CT, is often overused in syncope evaluation. Most patients show no abnormalities. CT is reserved for specific indications, like neurological deficits or head trauma. It aids in differential diagnosis of life-threatening conditions, ensuring appropriate use and management. Chest radiography is useful in syncope evaluation for identifying conditions like pneumothorax and pneumonia. However, routine use rarely alters management unless specific symptoms are present. A selective approach is advised, focusing on patients with abnormal signs or concerning POCUS results. In resource-limited settings, chest X-rays can help exclude cardiopulmonary causes. Treatment approaches for syncope vary by cause. Cardiac causes may require defibrillators or angiography. Pulmonary embolism and stroke need specific interventions. Volume replacement addresses dehydration. Reflex syncope involves education and referral. Tailored treatment ensures effective management. Risk stratification for syncope patients involves tools like the San Francisco Syncope Rule and Canadian Syncope Risk Score. These tools assess risk based on clinical factors. The Canadian score offers more nuanced risk stratification. Clinical judgment guides tool selection and interpretation. Managing syncope in the ED involves a risk-based approach. Low-risk patients can be discharged safely. Moderate-risk patients require observation. High-risk patients need diagnostic testing and treatment. Overlapping conditions necessitate individualized treatment, ensuring comprehensive management. A step-by-step approach to syncope in the ED includes stabilizing the patient, obtaining history, and performing diagnostic tests. ECG, POCUS, and laboratory testing guide diagnosis. Treatment addresses underlying causes. Education and follow-up plans ensure comprehensive patient care.